Hello, everybody. Welcome to Coffee Break. Although it's a little bit of a misnomer since I'm drinking water, it's really warm today in the Palo Alto area. So I'm going to stick to water for my coffee break. I'm Ellen Brown. I'm the Chief Medical Director of Pathways Hospice, and most of you will know me from Module 11, the talk on hospice. I'm really excited to be doing this and getting a chance to talk more about hospice, and hopefully we'll answer some of your questions in this talk. There have been a lot of good questions generated on the discussion post, and I'm hoping to cover some of the themes that have come up. One of the big one is hospice allowing people to live well until they die. And what does that mean? And I actually think there's a very personal answer because each person is going to have a different answer to that question. And we as clinicians need to make sure we ask that question or questions that will get at the answer. What's important to you? If you don't have much time left, but what do you want to be doing in the days, weeks, or months you do have left? And I have gotten varying answers to spending time with family, going on a trip, not having pain, being able to go to my paint classes, art classes. From a 97-year-old patient basically saying, as long as my mind is sharp, I'm the problem solver for the family, and everybody is calling me with their problems. And it was the utmost importance to him that we do nothing to interfere with his mental clarity. He didn't mind that he was bedbound and incontinent. And he said, these are just minor problems. My mind is clear, and that's what's important to me. And we might not have known that for this 97-year-old man if we hadn't asked. Similarly, I had gotten a question during the talk about, or a comment about, liking the way I was holding Sarah's hand during our the video with this module. And I tend to be a hand holder. I tend to form connections by holding hands. But I've come to realize not everybody is a hand holder. And there are some people who don't like to be touched. And I need to ask that question. Is this okay with you if I reach out, if I hold your hand? And allow time for an answer. So living well is what people say it is for them. And nobody can really answer that question except the patient. And what a gift we as clinicians can give people by asking the question and taking time to listen, and then seeing if we can marshal our forces to allow them to achieve what they're hoping for in the time they have left. So another big issue that has come up is, how do we take care of caregivers? How do we include caregivers? We know how stressful it can be to be a caregiver, both physically stressful as well as emotionally stressful. They are present and facing the loss of a loved one. And we in hospice, we view family members and caregivers as part of our unit of care. I think I've mentioned in the talk, traditional medicine deals with a patient. But in hospice, our unit of care is expanded to include family members and caregivers, and to listen and see what their needs are. Now, a common misconception about hospice is that we're going to swoop in and provide 24-hour care, and that isn't the case. Family members are counted on either to provide some of that hands-on care or to hire someone to provide some of that hands-on care. But our social workers and chaplains are there to provide emotional and spiritual support to family members and caregivers. Volunteers are there to provide some respite, allowing the caregiver time to go out for a walk, time to meet a friend for lunch, to go to a support meeting. And volunteers provide necessary respite. And if caregivers need longer respite, built into the hospice benefit are 5-day respite periods. And this can be hugely helpful. Caregivers need a break. They can get physically exhausted. I can remember one of my patients, or daughters of one of my patients, needed to take her son to college, but she was the main caregiver for her mother who had had a stroke. And she used the respite benefit so she could be a mom and take her son to college and come back refreshed and be able to continue to care for her mother. We also need to listen to the concerns of caregivers. They are the eyes and ears. They're the ones with the patient the 24 hours a day. And frequently, one of the concerns that comes up is, my loved one isn't eating. What can I do? And it's a long conversation on what to expect in terminal illness in terms of appetite, in terms of honoring a patient's preference that they're just not hungry. And if the patient's goals are comfort and quality of life, forcing themselves to eat can lead to pain or nausea, discomfort, and really isn't honoring the patient's wishes. At the same time, we recognize that for many family members, offering food, cooking food is one way they show their love. And we need to honor that, as well as provide them with alternative ways that they can show their love when their patient just isn't hungry. And not to take it personally if they've prepared a wonderful meal of the person's favorite foods and the person only takes a few bites. And sometimes near the end of life, a few bites are all that they want and can eat. Things taste differently often near the end of life. People may not get as much pleasure from eating. They have memories of favorite foods and they want that bite, but they're not going to eat the whole plate, or maybe more than a few bites. But there is education involved in terms of letting the family know what's happening with the disease process. Not to take it personally, but why so-and-so isn't eating, and recognizing their distress at the same time. Other things that caregivers notice is the withdrawal that normally occurs as patients near the end of life. They're awake less, they're sleeping more, they turn inward, spend more time reflecting and may spend less time interacting with family members. And again, providing family members with that information, preparing them for the things to come, can lessen anxiety, lessen worry, lessen the fear that they're doing something wrong. And so one of the things that the whole hospice team does is truly acknowledge what a great job caregivers are doing, how hard this can be for them, and reassuring them that they're doing the right thing or that they're doing a good job. And that's part of what we do when we come into the home. We're coming into the home as a guest, and we're honoring and recognizing families, family structures, and family caregivers. Sometimes there are hired caregivers who also need education or may need education in end-of-life care. And a lot of what the hospice team does is the education, how to safely move someone in and out of bed if their desire is to get out of bed, how to turn someone in bed so they don't stay in one position and get stiff. How to feed someone safely, again, if it's the person's desire to eat. What signs to look for as the change in condition comes or as death gets nearer. A lot of anxiety and fear of caregivers is the fear of the unknown. Now, we also have to be careful that we don't give them more information than they want. And again, it's asking the question and trying to find out how much information they want and then providing them with that amount of information. Finally, another question that has come up is, how do you choose a hospice? And that's a good question. Not all hospices are alike. They can differ in how long has this hospice been around? What's their reputation in the community? How many patients does each nurse have? Will they have time to spend time with my loved one? What type of service do they have at night and on weekends? What type of bereavement support will they provide after the patient dies? Medicare mandates that a hospice provide 13 months of bereavement, but they don't say what that has to be. Might be a letter in the mail, or it might be one-on-one counseling. What does your hospice provide? Does your hospice have physicians, and do the doctors make house calls? Those are just some of the ways to distinguish between hospices. If they have doctors, are the doctors certified in hospice and palliative medicine? Do they include my own physician as part of the care team? Because people are very attached to their primary physicians, and that doctor should be part of the hospice team. So, in closing, I hope I've answered some of the questions that have come up with hospice. I've thoroughly enjoyed this experience and hope that if any of you out there do have questions on hospice, post them on the discussion board. You can reach me, or you can reach out to a local hospice and find out more about what's available in your area. So thank you.